Hi. For those of you who don't know me, my name is Ann Uttermark. I am the Respiratory Therapy Manager here at Abbott Northwestern Hospital, and I'm here today on behalf of the Alina COPD Committee to talk to you about a COPD Care Coordinator pilot that we would like to do here at Abbott. Before we get started, I want to tell you a little bit about Hazel. Hazel is a woman I had the pleasure of meeting while I was shadowing another COPD Care Coordinator program at another system. Hazel was on her fourth admission in just over 2 months and was very upset to be readmitted yet again. She thought that we as healthcare providers thought that she was stupid because she kept being readmitted. We reassured her that was not the case, and we had a nice conversation with her. In that, we learned that Hazel was neglecting her own care. Her husband had Parkinson's disease and Alzheimer's, and she was neglecting her own care to provide care for him and get him to his appointments. She really wanted to go to pulmonary rehab, but gave that up for him. In addition, her daughter had moved in with them. Her daughter was recently homeless due to her substance abuse disorder and was not living a healthy lifestyle and was reintroducing bacterial infections into the home, and had also brought in her dogs that Hazel was allergic to. So her allergies were also flaring her COPD. After meeting with Hazel, we also learned that she was rationing her medications. She couldn't afford her medications, and so things that she should have taken every day or every other day, she was taking every 2 days or 3 days or 4 days, trying to stretch those medications out and make them last longer. After meeting with her, we went back. We were able to get a social services consult to help set up in-home care and medical transportation for her husband, get some support for dealing with the situation that their daughter had introduced into their lives. We looked at her insurance formulary and figured out which medications were actually covered by her insurance company, worked with her pharmacist and her physicians, and got her ordered on the right medications at discharge so she had a more affordable care option. So that's great for that health system. Does it matter here at Alina Health? Well, it does. COPD is the fourth leading cause of death in the United States. It sat in the number 3 spot for many, many years. It has dropped to number 4, not because we have done anything to improve the lives of individuals with COPD, but because the opioid epidemic in this country is so bad. Here at Alina, last year we had over 19,000 admissions related to COPD. About 30% of those were at Abbott. What we know about that 30% is they are primarily women. 51% of them are women. And they are in the age range of 55 to 84. So what we used to think of as the old man's disease is no longer the old man's disease. It's affecting everyone. Women have surpassed men in COPD-related diagnoses because of the smoking that became glamorized during their lifetimes. We also know that every admission costs us about $11,000. In addition to that, in the last 5 years, we've seen over $690,000 in penalties from CMS in regards to their readmission reduction program. Why does this happen? Why do these patients keep coming back? Well, they keep coming back because they have a very high burden of disease. Not only do they need to know about their disease, and they have to monitor their symptoms every single day. They have to know how to take their medications, and it is not as simple as taking a couple of pills. It is a lot of inhaled medications that they need very specific technique in order to administer properly. There is a lot of medical equipment that goes along with this. They have to know how to use that equipment, how to set it up, how to clean it, how to keep supplies on hand. They have to stay healthy. They have to get their vaccines. They have to exercise. They have to go to pulmonary rehab. They have to go to all their doctor's visits, and they have to quit smoking. It is a lot for these people to endure. In addition to that, the care is fragmented. Providers don't know the latest evidence in regards to COPD diagnosis, staging, and management. The medical record system has the latest evidence-based practice order sets loaded into it, but it is grossly underutilized. In addition to that, COPD tends to target folks of lower socioeconomic status, and they have limited access to healthcare related to their education, their finances, their employment status, and transportation needs. So they're not getting into the doctor like they need to. So for all of those reasons, we are proposing that we do a COPD care coordinator pilot here at Abbott. It does require 3 FTEs of respiratory therapists to make it successful. We would model it after the heart failure care coordinator program. So these patients would meet with a respiratory therapist while they're in the hospital. They would get a follow-up 1 business day after their discharge phone call to make sure that they picked up the medications they needed to pick up, that they had their questions answered, that their medical supplies that were supposed to get delivered got delivered, and that they remembered that they had these follow-up appointments to make with their physicians. In addition, they would get a follow-up phone call 30 days after discharge. What that would give them is answering any questions they had from those visits that they had, making sure that they attended those visits that they were told to go to, and seeing how they're doing and answering any questions they have about their medications or their disease state. Now, this does carry risk. It carries some financial risk to our organization. We have to pay for the FTEs. In addition, there is the potential for some previously reimbursed visits to not be coming into the organization from our private pay patient population. It's important because it ties us to our mission. So even if we have these risks, we also know that the mission of our organization is to provide exceptional care while we restore health, prevent illness, and provide comfort to all who entrust us with their care. This COPD Care Coordinator program does those things. It connects to our mission directly. So for all of those reasons, we ask for your support in considering a COPD Care Coordinator pilot, and we look forward to hearing back from you at your meeting next month. Thank you for your time.